I'm speaking about demand creation using peer approaches. We declare no conflict of interest. By way of background, I think we've really spoken a lot about the burden that this population faces. And permit me to move to the next slide, because this more really repetition. So, as mothers to mothers, we train peers of this age. And these peers live within the communities where the services are required. So they deliver health education, create demand for HIV services, and also provide a referral. They support integrated service delivery, combining HIV testing with the sexual reproductive health service education. And most importantly, they engage youth in designing and monitoring service delivery, ensuring relevance and uptake. So for us to reinforce this approach, we built a robust community partnership with local leaders, village health teams. Village health teams is one of the cadres in Uganda who are within the villages or in the communities, and also community health workers. So this help in normalizing conversations around HIV and reducing stigma. So community forums, outreaches, events, and peer dialogues provide instrumental in the driving of participation and awareness among adolescents. So this is just showing how we engage the community, right from community mapping, stakeholder identification and engagement, inclusive participation within the communities where we serve, and most importantly, also to collaborate with the other partners and making sure that there is linkage and integration in service delivery. Apart from that, we also conduct capacity building or strengthening in terms of training and supportive supervision. So I'll share with you some of our results we've seen for the period 2022-2024. As you will see, the maternal group, those are the ones receiving antenatal care and postnatal care, and then there are other groups, the other adolescent girls and young women, and also adolescent boys and young men. As you will see, the pointer is not working, sir. Okay. So, okay. Okay, as you see, the antenatal and postnatal youth remain above 90% in terms of HIV testing. Then the adolescent girls, we have seen in the 3 years that they have moved from 40 to 80%, more of a double. But when you look at the boys and young men, of course, we know while they are vulnerable, all of them, but the boys and young men is a difficult population, again, to reach. And we have seen that equally, sharply rising from 43% to 88%. But most important, yesterday we heard that Uganda is one of those who have not achieved the UN/AIDS targets. As you can see, the red line, all these are below the 1995 UN targets. So I'll speak quickly in terms of key achievements. For that period, we reached over 60,000 adolescents in terms of who we didn't know their HIV status. And increased HIV testing uptake between that period. We saw like I mentioned, adolescent boys increasing from 43 to 84. And when you look at this population, the adolescent boys and young girls, 15,000 were reached, and 45,000 also the girls and young women were reached. So these numbers reflect more than just scale. They signal that peer-led, youth-centered services work, and this model effectively bridges the service delivery and reach those often excluded from the traditional HIV programming. So in terms of, as I conclude, there are three key themes that emerge. First, peer-led programs significantly boost HIV testing uptake. And then secondly, integrating HIV and sexual reproductive health services increase access and efficiency. And what we also observe, thirdly, is user engagement and community partnership are critical for sustainable impact. So it's our plea that partners or policymakers really invest in and scale up these proven models to ensure that no young person is left behind. I know there are so many use models that have been tested. There's Zadir in Zimbabwe that our ministry learned from, and we implemented the YAPS model. As I conclude, Uganda can reach the 95 or the UN AIDS targets among youth, but it requires investing in these proven models, and boys and non-maternal girls need additional interventions to their needs. I thank you, and we acknowledge Viv. May I just check if Viv is still in the house? Yesterday I had her here. Yes, so thank you so much. We acknowledge Viv. This project was supported by Viv, and we also acknowledge the Minister of Health and the communities where we serve. Thank you so much.